This was a study looking into the different cadaver studies on the spread of local anesthetic after quadratus lumborum blocks. This was by El Sharkawi. It was, I think, last year. So they looked at a few studies, and only two studies, one done by Dam and the other done by the author himself, showed that the local anesthetic in cadavers can travel up to the paravertebral space. In different other studies, the kind of spread achieved was very different. There would be lateral spread. One of the studies by Carlin, which I'll talk about, actually showed that the transmuscular quadratus lumborum block can create spread to the L1 and L3 nerve root, which is rather unique, and their reasoning why it may be useful for hip surgeries. This was that study I was talking about by Carlin. And the QL1 and QL2 blocks did not have a very fascinating spread. They actually spread into the tap plane. But it was the transmuscular block that was very interesting. It went on to stain the L1 and L3 nerve roots, along with the genitofemoral nerve, the femoral nerve, the obturator nerve. All these entities got stained. But if you look at the area of injection, the point of injection that they illustrated in this paper, it looked like their injection was very, very close to the transverse process, very close to the neuraxis, which could be the reasoning. Technique plays a huge role in the effect of the quadratus lumborum block, which is probably the reason why many people tend to have different results in terms of spread when they do this block. I was talking about intravascular absorption. This is something that people don't talk much about, but we have to look into this when we talk about facial plane blocks. Now, there are two concepts to what we do, anesthesia and analgesia. And you ask yourself the question, what do facial plane blocks provide? Do they give you anesthesia or do they give you analgesia? Most of the time, and you look back at your own practice, and you're going to find that when you do these blocks, you're doing it for analgesia. Anesthesia is very specific. It's a very pure topic. If you are trying to provide good anesthesia, you should be able to create conditions that allow the patient to tolerate a surgical incision. So you either do a GA or you've seen complete blockade of the nerve when you do, say, a beautiful brachial plexus block. But analgesia is a very, very hazy term, and it's time we actually look for clear definitions of it. Analgesia is pretty much pain relief, in our case, after surgery. Anybody can do it. You don't need to be an anesthesiologist to give analgesia. You can give IV oral medications. People say you can do acupressure, acupuncture, hypnosis, funny things like that, which provide analgesia. And in the end, you might just have a patient who is really tough after surgery. He doesn't need much analgesia. So analgesia is a very vague term. We don't have clear definitions of it. And here we are with facial plane blocks providing analgesia. And this is why I'm harping on this topic a lot, because I looked up PubMed today. I saw 233 articles on the quadratus lumborum block, but only one case report where they used the quadratus lumborum block to provide anesthesia for a surgery. And they used it for a very predictable open inguinal hernia repair. I said earlier, L1 and T12 are right in that spot. So inguinal hernia is a great place to provide surgical anesthesia with the quadratus lumborum block. But there was just one article on it. There's the other concept of what happens when you give a local anesthetic, a nice strong dose of local anesthetic into a facial plane. So there's a review article that looked at 15 studies that measured the plasma concentration of local anesthetics after tap and rectus sheath blocks. There's only about 1 or 2 papers on the effects with quadratus lumborum block, but for all practical purposes, we look at ropivacaine in a facial plane block and see what actually happens to absorption. Now, they took 2.3 micrograms per ml as the toxic threshold for CNS symptoms. And these were the various doses that they used, 200 milligrams, 50 milligrams. There were two studies which used levobupivacaine and lignocaine. So we'll just ignore that. That's the one lignocaine one that you see up there. But if you keep 2.3 as the cutoff, you'll find that in some cases, the intravascular absorption of local anesthetic after a TAP block comes very close to systemic toxic levels. Though none of these manifested as eletoxicity, the plasma levels seem to reach that high a level. And this levels of local anesthetic absorption is dependent on many things, mostly the patient condition. Lower systemic levels of protein actually lead to higher plasma levels, as well as states like trauma where there's been a lot of blood loss, pregnancy LSAS patients are our prime customers for TAP blocks, cardiac conditions, renal failure, hepatic. They're all factors that influence the LA absorption. Also, very interestingly, is that if you get your local anesthetic to spread over a large area, like in a facial plane block, the greater systemic absorption occurs. So this is the reason why when we do facial blocks, that is, whether it is a PEX block, it's a serratus block, TAP blocks, QL or erector spinae blocks, there is a fairly large amount of local anesthetic systemic absorption. And what happens when this goes intravascular? It's very interesting. Murli is here today. He's a chronic pain guy. So he knows the chronic pain guys have been using lignocaine intravascularly for years. And it's only recently come into acute pain. And in acute pain, when you use lignocaine, which is the only drug we have that we can give intravascularly, there is significant anti-hyperalgesic and anti-inflammatory properties. And mainly, it reduces sensitivity and activity of the spinal cord neurons and a concept known as central sensitization, and it decreases NMDA receptor depolarization. There's a decrease in systemic inflammatory markers in patients who receive intravenous lignocaine perioperatively. And this is, again, something very interesting. The clinical benefits usually exceed the half-life by about 5.5 times. So if you stop a local anesthetic like lignocaine going intravenously, you might see the clinical benefits in some studies up to 24 hours. In some of the studies, it can go up to 72 hours. In fact, one of the studies that said that the peak effects of analgesia caused by IV lignocaine may be seen as late as 36 hours post-surgery. Last month in Daring Discourse of RAPM, there was a bit of a riffraff happening, and this was a letter written by Dr. Longquist and Professor Karmakar regarding the erector spinae plane block and other facial blocks in general. And they shared the same thinking that there is systemic plasma levels of local anesthetic when you use it in a facial plane block. And they proposed that future studies looking at analgesia from facial plane blocks must take into consideration and measure the systemic local anesthetic levels, because they also felt that this creates some amount of analgesia. Moving on to some frequently asked questions. This is not going to be much of a technical talk, it's more of a concept talk of the QL block, but many people like to know how much do you inject for a QL. Pretty much, I would say every block these days we give 20 ml syringes. And the reason why we give 20 ml, where few studies say 20 ml is good, plus after 20 ml, they only make 50 ml syringes. So that's probably the reason I use 20 ml for all my blocks. But on average, pretty much you can give 15 to 20 ml in the QL area. But of course, you need to measure body weight and see that you don't exceed toxic doses. What position can you do the block in? Well, it depends how comfortable you are with the needle and syringe in your hand. Most people like to do it in the lateral position. You can do it in the supine position, as you can see over here. You just need to ensure that you get enough space in the posterior flank so that you can wedge your probe in there and image the muscle clearly. Apart from the usual bouquet of complications with regional anesthesia, the usual complication that we can expect are injury to the abdominal viscera, because the kidney and the bowels are very close. If you don't look out for that abdominal branch of the lumbar artery, you can hit it and create a lot of bleeding. And though theoretically they say that you can block the roots if you go too much towards the neuraxis, I haven't seen it happen in my years of using this blockade. Can you use it elsewhere, just like they use the quadratus lumborum block pretty much everywhere in the body? Yes, it has been used for hip analgesia, but again, this is subjective to your usage and whether you want to really put this for a hip surgery. Of all the approaches we have, which is the best approach? Well, I leave it up to you to decide, because pretty much when you put 20 mils of anesthetic around a small area like that, pretty much gets spread all around the quadratus lumborum muscle, and it probably doesn't matter. I don't think there are too many studies that have compared each of these approaches and found that one is superior to the other. The outcome of studies have been vastly variable, which means that there's still a lot of scientific investigation that needs to happen before we can find the actual reason why this block works. So what would you select if you're doing a lower abdominal surgery? Pretty much anything would, that L1 and T12 are very consistently blocked with this block, so you can pretty